Excellent. Excellent. Rebecca, you can start letting people file in here. There we go. Look at them all. Good morning, everybody. We're just going to give it a minute or so before we get started. All right. Good morning, everybody. Hello. Welcome to BC Women's Research Rounds. I'd just like to begin by acknowledging that we are uninvited guests here at the WHRI on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And as a provincial research institute committed to improving the health outcomes of women, including those across the 2SLGBTQIA+ spectrum, we recognize our responsibility in the collective efforts towards establishing culturally safe healthcare systems and services that address health inequities among Indigenous peoples, especially Indigenous women, girls, and Two-Spirit peoples. And as we gather here together today, I encourage you to reflect on your positionality on these lands and your personal commitments to reconciliation. And as we're in September, I'm reminded that the month of September brings Orange Shirt Day, which is a day led by Indigenous communities to raise awareness about the intergenerational impacts of residential schools on children, families, and communities. And this month also marks Canada's 5th National Day for Truth and Reconciliation, which honors the children who never returned home and survivors of residential school. So it's really a time to reflect on the lasting impacts of colonialism and to support truth and reconciliation. And here at the WHRI, we recognize that advancing reconciliation includes action and accountability. So as part of our commitment, one of the main strategic goals in our new 2025 to 2028 strategic plan is to advance Indigenous women's health as a research priority across the province. And we're really dedicated to working in partnership with Indigenous health leaders and communities to support health research that is culturally safe and grounded in community. So with that, I am very pleased to be able to introduce our round speaker for today. Marie Klingberg-Allvin is a registered nurse, registered midwife, and a professor in reproductive health at the Karolinska Institute. She holds a PhD in international health from the Karolinska Institute and has over 24 years of experience in global sexual and reproductive health and midwifery, particularly in low-resource settings. Her research has focused on safe abortion, post-abortion care, contraception, and the sexual and reproductive health of migrants in Sweden, with a strong emphasis on comprehensive abortion care. Professor Klingberg-Allvin leads an interdisciplinary research group at Karolinska with expertise in midwifery, health systems, policy, health economics, healthcare quality, and clinical research. So I'm thrilled to be able to pass the floor to Marie.
Thank you so much, Catherine, and thank you so much for having me here. So I am actually in Vancouver because I am based here with my family at the moment. So I work on distance for Karolinska Institute, but I'm also affiliated to UBC, to the Department of Obstetrics and Gynecology, and also with your Women's Health Research Institute. So yeah, I will. I'm happy to be able to actually give you a little bit of a brief presentation about a fairly new research topic for me. I would say it's. I have been like in women's reproduction for 25 years now in different areas, and primarily, as you said, comprehensive abortion care. But menstrual health is something that I started to dig into beginning of 2020 together with colleagues and partnerships in Sweden as well. So I will start to share my screen, see if it works. You can see that, and I will continue to share.
Looks great.
Looks great. Thank you so much. Right. Okay, so the objective with my talk today is to give you some definitions of menstrual health and also brief a little bit about the key dimensions in this, and also a very broad thematic overview of the global research trends and challenges. And then move over to this a little bit of a spotlight on ongoing and planned research we are currently conducting in Sweden and in other low resource settings where I'm also engaged and active. And finally, also just outline some future directions for research that may maybe inspire, and maybe we can also see how we can start and continue to sort of collaborate and build partnerships around this topic. So what is menstrual health? There is a fairly new definition, I would say, by Hennigan, 2021, that this is a state of complete physical, mental, and social well-being in relation to the menstrual cycle. It's not merely the absence of disease. It emphasizes the meaning and agency. It also recognizes that menstruation is a natural and important aspect of life. However, this also poses challenges for women to different degrees, which has to be acknowledged, and their needs and preferences has to be met. So if you break this down, you would need to look into individuals and societies, I would say, knowledge and literacy. Do you have access to accurate information and skills to manage your menstruation confidently and respectfully? You need to have access to materials and facilities. And of course, this differs. So if you go to Somaliland, this is actually about having access to a toilet and to be able to wash your hands, as well as having access to affordable menstruation products. It's also about pain and symptom management, and access and to timely and respectful care and support when needed. And when you look into the psychosocial dimensions into this, it should be a supportive environment that is stigma-free, where you have spaces in school, work, and in community society where you can feel that you are supported. And the more high-level holistic meaning is that you recognize that this is personal, cultural, and social aspects of menstruation and across the life course. So it's from menarche, adolescence period, and through the reproductive years, up to perimenopause and menopause. So in my research group, we have also chosen to have a life course perspective. So being a midwife trained in Sweden and looking into the scope of practice for midwives in Sweden, I would say we provide 85% of the healthcare services that is related to women's reproduction. So it is from early age. You work in youth clinics, you are out in the schools talking and give information about sexual reproductive health and rights from early age. You go to your midwife in the maternal health clinic during your pregnancy, and it is your midwife who supports you when you are giving birth to your child in the hospital until something abnormal or complications appears. So the life course perspective is something that I carry being a midwife, that is important to be able to meet women's needs and preferences during their life. So briefly, we could say that, I mean, early experiences, if you are a young girl and when you enter this, it could shape your future health. So the timing of menarche, access to education and support, and this first experience influence your health literacy and also your healthcare seeking patterns. Um, so untreated dysmenorrhea, heavy menstrual bleeding can lead to different abnormal and complicated. And you can also miss important opportunities in life, which I will also present a little bit on later when it comes to school absence and work absence. So having a life course perspective is also important because uh, it accumulates this impact across stages during life. So it interacts with your fertility, your pregnancy, postpartum recovery, and also eventually perimenopause. And if this is undressed, it compounds later in life. So having a life course perspective means also that it's important with this close healthcare encounters and to be able to feel supported and met, but it also have like more of a systems perspective because it intersects with equity and also with rights and justice. So if we look into the global research trends and challenges, so I decided, so if you would look into the literature, what is actually published, you would notice that there is a lot from low resource settings and the challenges. And that is because we have the SDG number 6, which is water, sanitation, and hygiene. So the global programming on WASH has actually had impact, and it has we have pretty much evidence around this. But apart from this more basic like access to facility and products, the fact that healthcare providers and teachers needs to be educated, and also the limited budget and the focus in these settings impact, the fact that they have not really yet moved beyond this, and there is still a lack of the more holistic approach to menstrual health, which is not only product and wash issue. So neglecting education, psychosocial support, and health systems integration of this. This is not different from Sweden or Canada, I would say. So, I mean, if we move over and look into the publications and access evidence right now, it's very scarce, I would say. And this is more based on my knowledge of my own healthcare system and school environment, that services exist, but it's siloed, and this needs to be coordinated. And if you would look into data, Sweden is really, really good at register everything we do within the healthcare system, but to follow up on menstrual health aspects has been lacking. So I will present to you also the sort of the first population-based data we have now in Sweden. And there is also in Sweden and elsewhere equity gaps. So you have marginalized groups, migrants with different origin, youth with disabilities, gender diverse individuals remain underserved, and that data is not visible. So without this, we do know as researcher that it's difficult to monitor progress and hold systems and responsible parties accountable. So to move over and give you a little bit of a Swedish research spotlight. So my research group at Karolinska Institutet is based at the Department of Women and Children's Health, which is one of 21 in Karolinska Institutet. And in my division, obstetrics and gynecology, we have this research group that on this topic, we have chosen to have the life course perspective because we want to emphasize that it is from menarche through adolescence and the reproductive years up to menopause. We also use an intersectional lens in our design and methods of our research, quantitative and qualitative, to recognize gender identity, migration status, and also socioeconomic background and disability, if there is. And our group is interdisciplinary, so we integrate insights from midwifery, public health, clinical medicine, social sciences, and also health policy and systems research. So meet the team. So this is our team that is actually focusing on this topic right now. And so the team work actually both in Sweden and also in Somaliland, where we have a very active research in collaboration with different institutions, with university, the Midwifery Association, the Ministry of Health, and also hospital and facilities at all levels. And when we embarked this research area, it was actually started by a first study that the Public Health Agency of Sweden asked me and my research group to take on, which was to just do a scoping review of the evidence in the Nordic countries. And since then, this was like 2021, we have also come into agreements, so they are funding 2 PhD students, and they also support the population-based data collection and enables us to conduct also complementary qualitative studies. And working with the Public Health Agency of Sweden, who also published the National Strategy for Sexual and Reproductive Health and Rights in Sweden, 2020. So working with them also ensures that we can have policy impact and that our evidence is actually translated into practice. So the key research areas as of now is that we are looking into symptoms and school absence, and that is population-based data. And then we dig deeper into women's experiences, so more about like stigma and norms and access to healthcare more in depth, which is qualitative data. We have a specific study that is actually looking into migrant women who has undergone female genital cutting. And this is also part of the cross-context research we have between Sweden and Somaliland. So in Sweden, the largest immigration group is people who was originally born in Somalia and has moved into Sweden and lived with us for decades. And adolescence and sport is another track here. So we have floorball players, young ages, and their coaches. And then we also have just started a multi-language study to start to capture women's needs and preferences in relation to menopause. So I will give you a little bit of a snapshot from these different studies. So as I told you, we started off to do this scoping review, which is published and accessible for all of you. Basically, what we found was that there is gaps. So under research voices, you have young adolescents, you have people with disabilities, refugees, immigrants, gender diverse individuals, and also people experiencing homelessness in Sweden. So we used this. It was published 2024, and we also had we applied an intersectional lens when we were analyzing the existing studies, which was 22 from Sweden, Denmark, Norway, and Iceland. And what we also could see was that the main, the most, the majority of the publications was on pain and endometriosis, and it was focusing on adult populations as well. So with this, we decided that okay, we need to understand on a population-based level actually symptoms and also more about absence and how these symptoms actually impact young people in Sweden. So this is a population-based data set we collected 2023. It was the Public Health Agency's study, and then we were, as researchers, asked to analyze and report on this, and we have one PhD student on this topic. So the total number of respondents was around 9,400, and among these, around half is reporting menstruation, and they are 16 to 29. So not surprisingly, I mean, menstrual related symptoms were reported by 90%, menstrual pain 76%, heavy bleeding 40%. This is self-reported. So this is how they perceived being heavy bleeding. So mood changes was reported as well by 76%. So, and then when we moved on in this, we could also see that 16% of these women, young women, girls, they stayed home from school every period during the past 6 months due to menstrual symptoms. And 14% refrained from physical activity during the past 6 months. 68% knew of those who experienced menstrual symptoms. They knew where to seek help, but only 36% have actually sought help and support. Or across all these variables, we could also recognize that participants with other gender identities than girls consistently reported higher prevalence of symptoms and absence. So this is just in pipeline now to be published actually in BMC Public Health. So I will be able to share it later with you. We are just proofreading right now. So the qualitative part is we decided to do actually parallel with this study. And we interviewed 16 young people, 18 to 28 years old, and we analyzed with reflexive thematic analysis. And this is just a brief. Menstruation was seen as a sign of health and an important identity, but it also caused physical and emotional symptoms that limited daily life and social relationships, as well as sexual and mental well-being. And stigma and society norms contributed to shame and avoidance of activities, and it also delayed healthcare seeking. So what came out is the value of timely treatment, of course, and supportive environments is important to reduce these negative impacts of symptoms. This is published 2024, also in BMC Public Health and accessible for you to read more in detail. So this is a study that is actually ongoing and we are still analyzing it and writing the manuscript. I just wanted to share that we are actually doing it, and that is menstrual health across context. And So women living in Sweden that had undergone female genital mutilation cutting have been interviewed. And the preliminary theme right now is between pride and stigma, and it illustrates the complex meaning of menstruation among women with experience of FGC, FGM. The finding is very similar to our previous study in Sweden with a diverse background of informants, but what we found here is more the encounter with Swedish healthcare system and how these women actually felt that they were discriminated and racified because of being reporting that they have undergone FGM, FGC. So this will be a report that will be published by the Public Health Agency, and we are also writing up a manuscript parallel with this. So results are forthcoming. So another topic within this, but a very important topic, I think, being in sports myself when I grew up. I'm also, I am a hockey mom, a soccer mom, cross-country mom. So for young people to be able to participate in sports without any implications is important, I think. So adolescents and sports to create menstrual health friendly environments. So going back to 1988, you see me, myself, and my teammates in my floorball team. I can still remember that we this was a hot topic. This was like it was challenging to manage during these years when you wanted to compete and perform and be part of a team, and the environment wasn't really supportive of how you could navigate and manage this. So we actually managed to have funding 2 years ago to do this study, and it is several sub-studies in this project, and it's Eva Åkerman, who is a postdoc and researcher in my group, who is responsible for this, and we have interviewed 16 girls, and they are in the age ranging 12 to 18. And this is still also under analysis, but we can recognize that there is definitely challenges still, but also suggestions for how this could be moved on. And we are also waiting now to analyze. We are waiting to analyze quantitative survey as well. So we have around 800 participants in a quantitative survey, also floorball girls in Sweden. And we are also analyzing qualitative data based on interviews with coaches. And I would think that whatever comes out of this study, we are focusing on floorball, which is one of the biggest sports for girls in Sweden, along with soccer and hockey. So I think this would be probably, it's more of a general, I think you would find the same results even if you moved into the locker room in soccer, for example. So we are excited to be able to embark this area as well, and I can report back later and share the future the publications coming up eventually. So the research we have in pipeline right now, and also collaborations, is that we have this data set with the population-based data that is actually very broad. It's sexual reproductive health. And we are also looking into if these individuals that responded feel they are oppressed in their sexual and reproductive health and rights. So that is also a PhD student working within that field. We will also get access now to new data that is called MENS 2024, and that is also population-based data with women aged 16 to 59. So this is a data set that is spanning another age group, and we had an opportunity to include questions here that is also more spot on monitoring menstrual health, the indicators needed to include to be able to analyze, interpret, and draw conclusions. We are continuing, we are doing the qualitative studies, and the one ongoing right now is the experiences of menopause, which we will conduct in Swedish, Persian, Somali, and English to ensure inclusivity. And we also have data collection in Somaliland, and that is spanning adolescence to menopause. It's mixed methods, survey, and interviews, and we'll also inform, we will also use a stakeholder dialogue approach where in Somaliland, for example, all these evidence will come together and we will actually discuss with Ministry of Health, with Ministry of Education to see how menstrual health can be streamlined and coordinated in a context like Somaliland to move beyond the WASH approach. So, and we also have a strategic collaboration with Dr. Laurie Brodo and Dr. Gina Ogilve, and that is that we have submitted an application to Swedish Research Council and addressing menopause care gaps in Sweden, investigating symptom prevalence and the feasibility of integrating menopause care within the existing healthcare pathways. And we are waiting this decision in November. I hope that we will be able to do this together with you. It builds on the HER-BC study where you have done quantitative and qualitative data collection around midlife women's health. So this week actually is part of my research group. So to the left is Clara Abrahamsson, and she is the PhD student analyzing the population-based data as well as qualitative. She was in the parliament and did present these findings to our MPs and also had a discussion around this. So this is also one important way to assure that we move forward in this. It is actually a hot topic in Sweden as well as among politicians. So there is a mutual interest here to meet the needs of women over the course of a life. And I would like to say that menopause is also a very, very important part of this. But the thing is that we do not have any data as yet on this. So from evidence to action, driving policy change. This is one example, of course, but also the fact that we are having a health system policy expert in our group. That is Dr. Christina Madison. She was trained at McMaster's University, McMaster Health Forum, and we always have a component. So we collect the data, the evidence, and then we have a component where we also bring in stakeholder dialogue to drive a policy change as well. So moving beyond publishing scientific evidence to actually co-create, change with policymakers, practitioners, communities, most importantly with women. And another core priority I would like to bring up is that there are a set of like global core indicators for menstrual health, but that can be implemented in every country and used in several countries. But I think we need to continue to look into these. And so for Sweden, as well as other countries, I would say to evaluate adolescent-friendly pathways, especially for heavy bleeding, and everything that is borderline abnormal. I think we are missing out on diagnosing endometriosis, which is common in Canada as well as in Sweden. And to find treatment models and support models for this. Conduct implementation research, of course, in schools and workplaces and sports settings. So based on our research, we have also started a course at Karolinska Institutet that is menstrual health from a life course perspective. And we are currently giving it for the second time. It's a diverse group of professionals in these courses, which is very fruitful. And we also start to have now actual missions from the healthcare system, where can you educate our midwives working in youth clinics? Can you educate people who are in charge of large number of personnels in the healthcare system as well as outside? So there is a growing need for improved knowledge. And as I said, advanced menopause and workplace policy. We are also using our data to look into the cost effectiveness of evidence to show that, I mean, if girls are missing out from school every month during high school, what sort of impact does it have on their life and society? So costing data and analyze the actual impact for society as well as for the individual is something that would need to be, to dig it deeper into together with the health economists. Yeah, and overall, of course. So the approach to engage policymakers and end users early, co-create the solutions, and translate evidence into national guidelines, training packages, as well as financing strategies. Thank you very much. That was my last slide, and maybe we can open up the floor for
Absolutely.
discussion and insights, and yeah, open up.
Absolutely. Yeah. So if anybody has any questions, please raise your hands. I see lots of applause icons. Go ahead and unmute yourself, or I can read out any questions that appear in the comments. Gina, I see you.
Sorry, I'm on my phone and I can't quite figure out how to put my hands up. Marie, always so impressive to hear your work, but I've never heard it in its totality like that. So just really impressive to examine the inquiry that your team is doing. Really great. WHRI has, for its strategies for the next year, we've got numerous strategies, including our Pillar 1 strategy, to really understand some of the biological underpinnings of women's health. From your vantage, where do you see the biggest gaps from a sort of basic science approach? Because I really feel we at WHRI have an opportunity to sort of take charge and take leadership on understanding that inquiry. So what in your work, where do you see the largest sort of knowledge gaps from just the basic science realm?
Yeah. Oh my gosh, that's a tricky one. I mean, I am more a public health scientist, so
Mhm.
but I do collaborate with. So in my department right now, we actually submitted an application to have an excellence center in women's health from a life course perspective, and we have like preclinical studies, like even yeah, preclinical, clinical, and all the way up. So I mean, I would say that diagnostic tools to actually early, I mean, identify endometriosis. I mean, what we see in our data is that symptoms are normalized, and young girls and women are suffering, and they are missing out on opportunities in life because of this. So for me, I wouldn't be able to say what is needed from, like, treatment wise. We have contraceptives to should could be, that would, if we could change the discourse around contraceptives, that it's not only indicate that you are sexually active and
Mm.
you want to protect yourself from pregnancy, it's a treatment. And girls, young girls, we insert IUDs on young girls in Sweden. I know you do that here as well, but I think the discourse around contraceptive as a treatment and not
Yeah.
like
Yeah, I mean, I've heard people say we should change the name from contraception to hormone treatment, or whatever the language is, so people don't think.
yeah,
Yes, we should address the stigma in and of itself, but also it's this great treatment that, because of stigma, especially young women won't touch it.
yeah, no,
Yeah. So diagnostics being a focus to understand what's quote unquote normal, not that it, and what is sort of something requiring further assessment. Okay, that's great reflection. So thank
yeah.
you. Thanks very much.
Any other questions? People feel free to raise your hand or pop it in the chat. So Marie, you mentioned that there's a lack of administrative or population-based data in terms of like perimenopause, menopause, and impacts. And you also mentioned, I think it was the men's 2024 data set that's newly available. Do you think that information in there is going to help address some of those gaps, or is that still something that needs
Yeah,
further?
yeah, I think it's always challenging to collect population. It gets more and more challenging, I would say, to collect population-based data. But in Sweden, we are still try to stick to this and do these on a regular basis. So the Public Health Agency do these like big population-based data surveys. And so in Sweden for menopause, we only have data from Stockholm, for example, and what we can see is that so women living in Stockholm, I think it's 5% to actually seeks healthcare during menopause, and it's even lower in if you just have look into how many women actually have been to an appointment because of menopause, it's like 2% in the country, and very low both. So you can see, yeah. So I'm very excited. I'm really hoping that we will be able to do this, because Sweden is a diverse country in a way, geographically. You have large populations in the cities, but you also have, like, in the north, far away from healthcare and like we need to look into how can women have equal access to healthcare, no matter where you actually live. You have the same in BC, the same challenges, of course. So
And
yeah.
do you think that like the lack of care seeking at that time is caused by, I mean, I'm assuming it's not by a lack of symptomology or bothersomeness. So is it just a lack of information or knowing that there may be viable treatments available?
Yeah. Oh yeah, of course. I mean, there is treatment, right? And there is a lack of. It is same thing with menarche, like early. I mean, the normalization. Like, okay, yeah, this is normal for women, and but there is a huge lack of awareness, I think, for the like the perimenopause, and the fact that it can start when you're 40. I think there is an overall, people assume it's like when you turn 50 something happens, but you have this. So yeah, I mean, but it's a huge, I can see now in social media, like, you have clinics opening up for menopause counseling and private, which is very, in Sweden, everything is tax funded. So the private alternatives are available in Stockholm, but very, 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 very few. And so that is why I mean, to address this and to look into the existing healthcare system and the pathways. So where can we increase access, I mean, it's midwife are core professionals here, but of course, you also meet nurses, and your family doctor is also an entry point. But then it is the midwife who actually have both the time and the expertise to build competence and be responsible for this. We prescribe contraceptives and eventually also menopause treatment. So
I see your hand up, Rosie.
Yes, thanks for a wonderful presentation. I was wondering about the healthcare professional awareness or knowledge, and also research on premenstrual disorders, and specifically premenstrual dysphoric disorder or PMDD in Sweden, especially as part of the life course approach, because I think it was a Swedish paper recently that showed that, I think it was PMDD, was associated with perinatal depression. And I was just wondering, so about, is awareness possibly better in Sweden than it is in Canada? And also, do any of your data sets include consideration of the range and severity of symptoms that would describe PMDD?
no, we did not have that in the population base. That would need to be like a sub-study to do. You cannot cover everything in these more broad surveys. But of course, and I mean, and this is why it is important to have the life course perspective, because there are so many different events in a woman's life during the reproductive, if you look into her reproductive history, and to understand, and that is why also the midwife is a core person, because you meet your midwife when you are a young person. You meet her also in the maternal health clinic, and you not only during your pregnancy, but postpartum, and for contraceptives, and for cervix screening, everything. So, and to also pick up these like postpartum depressions and whatever. So, but yeah, so that was a short answer. It's not really my topic. That I have not digged into the research around that more specifically. But thank you. It's an important aspect, of course.
We have a couple of questions in the chat here I'll read out. So first one's from Miriam, asking, from your perspective, what are some of the key variables on menstrual health that are missing from the current health administrative data that you've seen?
Oh, I mean, if you so when you refer to health administrative data, would that be that what you have in your healthcare system
Or even from the Swedish perspective. So you were
Yeah, so,
mentioning
so from the
yeah.
Swedish perspective, yeah, I mean, there is a huge lack. So I mean, we would need to, although Sweden have these wonderful hundreds of registers on everything, this is actually something. And I think with our results now, that is a cumbersome process though, to go into like, okay, you have to change this, but based on the data that is actually just will be released now, we can actually go back and see, okay, what are the most important indicators to monitor in our setting? And then it will be different for every country. Yeah.
Good point. Another question from Emma. For the qualitative components of your study in both Sweden and Somaliland, how are you recruiting participants? Oh,
Yeah.
great question.
Yes, great question. So I have worked with Somaliland since 15 years. So, and that has been a capacity building program, starting with an online master in sexual reproductive health and rights. We were delivering from Sweden and we traveled as well. And then eventually also 2 PhD students. And so we have a large research team in Hargeisa in Somaliland. They have also just recently opened up a, a research center at the hospital in collaboration with the local university and the Somaliland Nursing and Midwifery Association, which is a strong driving force actually behind capacity building for midwives, education as well as research. So yeah, so as an example, I'm right now I'm supervising our midwifery students which are writing master theses. So I have 2 Somali-speaking midwifery students in Stockholm. They were born in Sweden, but they are fluent in Somali. And then I connected them with the team in Hargeisa, and now they are conducting interviews with women in Hargeisa on menstrual health in teams. And then they are transcribing this and they will present it and analyze the coming weeks. And in Sweden, I have this broad network with Somali-born people, midwives, who work clinically, and they also have. I mean, Somalis are wonderful in networking. They are very supportive of each other, and they know each other very well. So in Sweden, if you get access to that through someone who is respected and trusted, and they do interviews for you, and then of course, and then you feed back and you meet them, and it's like a long-standing relationship you build over years. Yeah.
Great. Anybody else with any final questions?
Emma?
Yep, she said thank you. Just thanking you for that answer. It's really great to hear. I think, yeah, community engagement is always the answer to these to these questions. Build trust over many years.
Mhm.
Just go ahead and raise your hand or pop it in the chat if you have a question. I'll just give another minute for you to think. Well, if not, I would just really like to thank Marie for this wonderful presentation. Such a broad survey of the data you're doing in the menstrual health space. It's been fascinating to hear more about. So, and I can see everybody's thanking you for this wonderful presentation. So thank you. And thanks everybody. I hope you have an amazing weekend. Soak up the sun while it lasts.
Yeah. And thank you so much for inviting me. And I just want to pop out that like if I am based, I'm just 10 minutes from the hospital. I also Dina offered me a office space, so I will be around a little bit more. And if anyone, so being affiliated professor now to the Department of Obstetric and Gynecology, I think I can also step in and be maybe guide, mentor, supervise. I mean, whoever student wants to embark this. I know you also have in-house competence, of course, but I'm happy to do that. Yeah.
That's an amazing offer, Marie. I'm sure that there's some folks on here that are will probably take you up on that. So spread the word, everybody. Thank you. It's been wonderful.
Thank you so much.
Yeah.
Enjoy your Friday.
Enjoy your Friday, everybody.
Maybe the last days of sun.
It might be the last day of sun. Yeah. Thank you.
Thank you so much. Bye.